So I think we have come a long way since 1960s, where we had radiotherapy, then developed MOP, and then ABVD had improved the outcome, decreased the toxicity, and then there was a big lull in the treatment of classic Hodgkin's lymphoma up until now. And now suddenly there's an explosion of options that we have for treating patients with classic Hodgkin's lymphoma. Besides brentuximab vedotin, I would like to mention that the PD-1 inhibitors also have opened another gateway, another way to use immunotherapy in the treatment of this hematological malignancy. Now, in the beginning I said, yeah, 75% of the patients with classic Hodgkin's lymphoma most likely will be cured with the modern therapy. But those 25%, they are not that lucky, and only 50% are salvageable by autologous stem cell transplantation. And even then, patient getting into the transplantation in a PET2 negative fares much better than transplanted with PET2 positive disease. And hence, we as physicians, oncologists, and transplanters should do our best to take the patients to the transplant and then keep the remission status as long as possible. Going back to the echelon, patients that are given AAVD, 1/3 less patients are requiring transplantation compared to the patients that received ABVD. Now, I'm a transplanter, I like to transplant, but I'm happy when my patients do not need my expertise. That means they are not relapsing or relapsing less to see a patient, to see a transplanter. And I think BV has helped in some of those patients that do not need to go to the transplant. But for those patients that requires to go to the transplantation or relapses after transplantation, beyond BV, I think we must recognize the role of the PD-1, PD-L1. To explain what PD-1 and PD-L1 antagonists do to us, so when I was in medical school eons ago, I was always amazed looking at the cut section of a Hodgkin's lymph node. Right in the middle is this large owl-eyed cancer cell looking back at me. And the cell, the cancer cell, is surrounded by multiple inflammatory regulatory cells like macrophages, eosinophils, monocytes, dendritic cells. So I always wondered why this cancer cell is thriving amidst the sea of killer cells. And we did not realize it at that time, but now we know there is a symbiosis going on. As I mentioned, CD30 ligand through these surrounding cells maintain a nurturing environment by direct ligand or cytokine release, and the cells are almost like nurtured by those mothering cells around the cancer cells. On top of that, the Hodgkin's-Ritz-Sternberg cell has a genetic predisposition to upregulate a particular segment of a chromosome called 9p24. And what 9p24 does, it upregulates an antigen called PD-L1, which is programmed death ligand that interacts with the T cells in the surrounding through the programmed death 1 receptor. And this interaction basically tells those T cells that are surrounding the cancer cells not to come in and not to fight. This really sends a negative counter-regulatory stimulus for all the surrounding cells not to hurt the Ritz-Sternberg cell. So it is almost like the cancer cells are wearing an armor and surrounded by a moat where all these inflammatory cells cannot reach. So the drugs like nivolumab or pembrolizumab, which are the PD-1 antagonists, are blocking these negative counter-regulatory pathways, making chinks in the armor, making the drawbridge drop. So the cancer cells are exposed to the surrounding environment of the T cells, which will just cross those moat, enter through the chinks in the armor or in the fortress and kill the cancer cells. So this is a very novel and exciting way of improving the response of refractory Hodgkin. So the earlier studies showed single agent had 87% overall response in relapsed refractory Hodgkin, with around 17% complete response. One word of caution of PD-1 inhibitors, because it upregulates the T cells, patients sometimes can present with symptoms like immune enhancement, like autoimmune. So patients may present with inflammation of the eyes, skin rash, diarrhea, pneumonitis. Of course, we know how to treat them with steroid, but one has to be vigilant. Another word of caution, patients with Hodgkin's disease who are relapsed after autologous transplant, and we are contemplating of using either single agent nivolumab or pembrolizumab or in combination with BV, and then we are planning to take them to the allogenic stem cell transplantation. Remember, these drugs have long half-life, and when the donor cells are introduced, the donor cells will find the body as foreign and will initiate graft versus host disease. And now, with the PD-1, PD-L1 antagonists in the system, those graft versus host disease will be very much intensified, leading to exacerbation of graft versus host disease. So one has to be very careful about selecting the donor, selecting the patient, the time interval, and how to take care of the increased graft versus host disease.